We look forward to continuing to engage with broader audiences through unique initiatives like tonight's event and our Women for Women's event that start important conversations about equitable access to healthcare and the role of Women's College Hospital. After your dinner this evening, we'll have the privilege of hearing directly from Dr. Danielle Martin, our keynote speaker. Dr. Martin is a family physician and Vice President of Medical Affairs and Health System Solutions here at Women's. You may also know her as a powerful advocate for Canada's universal healthcare system and a leader in developing innovative solutions to improve the system and make it more efficient and sustainable for all. We're pleased that Dr. Martin can be here to speak to us tonight about her advocacy work, her commitment to healthcare equity, and how Women's College is leading the way in creating better access to care for all. But first, it's my pleasure to introduce you to Marilyn Emery, President and CEO of Women's College Hospital. Marilyn has led the hospital since 2007. She has navigated the institution through some of the most innovative and exciting changes in its storied history, including the construction and opening of this beautiful building, which positions Women's College as the first and only fully ambulatory academic hospital in Canada dedicated to advancing healthcare for women. In recognition of her extraordinary career as a leader in the healthcare sector, Marilyn has twice been named as one of Canada's most powerful women, Top 100. Please join me in welcoming Marilyn Emery.
Thank you so much for initiating this President's Dinner. Good evening, everyone. It's lovely to have you here. I want to begin by thanking each one of you on behalf of the staff, the clinicians, and the volunteers of Women's College Hospital for your tremendous contributions and your interest in the care, research, and innovation that is closing the health gaps that affect women across the diverse communities that we serve. Our donor community does not only support this hospital financially, you are our partners, our champions, and our advocates. You provide us with confidence, resources, and flexibility to constantly dream bigger and to strive for more and more on behalf of our patients. We simply could not do what we do without you. And for that, we are very grateful. As you've heard from Mary, it truly has been an extraordinary year for Women's College. And 2018 promises to bring even greater impact as we pursue our strategic vision to revolutionize healthcare for women and girls with a determination that grows stronger each day. Excuse me. Like our foundation partners, Women's College is also developing a new strategic plan that will take us through to 2022 with a very sharp focus on integration, innovation, and health equity. A focus that will see this hospital continue to evolve as a world leader in care, research, education, and system solutions that create a more efficient, a more sustainable, a more woman-friendly, and a more impactful healthcare landscape for all. Throughout the process of developing our strategic plans, we consulted with more than 600 stakeholders, including partners throughout the hospital and the broader community. We asked many questions. What will be the next era of health for women? What are the biggest challenges facing our health system? And how can Women's College help solve these challenges? How are the health needs of our communities evolving based on the continuously evolving technologies, health system pressures, and social determinants of health? Through these discussions, we developed 4 key strategic goals that will strengthen our role as a health system innovator, a leader in clinical care, research, and education, and a capacity builder, and a strong advocate for health equity and access. These 4 goals are all rooted in a vision to revolutionize healthcare for a healthier and more equitable world. Our commitments are to revolutionize health for women and pursue equity for all, to to revolutionize care and the care experience, to revolutionize health systems, and to advance sustainable, world-class research, innovation, and education. So these are the 4 pillars that will ensure we continue to lead the evolution of healthcare, not only here in Canada, but around the world. And today is an important day on that journey. This morning, we kicked off our hospital accreditation survey. I understand that you've all heard about it from any one of you that encountered a hospital staff member at the reception. This audit is led by Accreditation Canada. It's a voluntary process by which hospitals measure our clinical and operational performance against more than 1,200 established standards for health providers. In our last accreditation survey in 2013, we achieved the status of exemplary standing from Accreditation Canada. This is the highest ranking a hospital can achieve, and one that not every hospital attains. So we have set incredibly high benchmarks for ourselves. Throughout this week, representatives from Accreditation Canada are closely surveying and observing all of our processes and procedures to ensure that we adhere to the highest standards of quality care. They're also talking to patients to hear what our patients have to say about us, and our community stakeholders as well. So we look forward to sharing our accreditation results with you over the coming weeks. So I'd like to end with once again thanking each one of you for your extraordinary commitments and your interest in Women's College Hospital, and for your powerful belief in our mission to revolutionize healthcare and to close the gaps in healthcare. It's because of you that this hospital is leading the way in creating a healthier and more equitable world for all. We are so grateful.
Thank you very much, Marilyn. Now I invite you to enjoy your dinner and conversation, and Danielle Martin will speak to us after dinner. Thank you.
Thank you so much, Mary, and thank you, Marilyn, for allowing me to spend this time with all of you together this evening. I'm going to be speaking for a little while, and then I've been asked to leave some time for some dialogue and interaction, which is always the best part. So prepare your questions, comments, and challenges. I think many of the folks in this room know that a lot of the work that we do in this organization is about trying to innovate and reorganize the resources in our healthcare system in order to try to make it more efficient and improve access for people. But I'm actually not going to talk about that tonight. Because I think, like many people in this room, I have been so affected by the news of the last many weeks as it relates to what is really a time of unprecedented social attention to gender-based sexual violence and harassment. And as we grapple with the reality of generations of silencing and the self-silencing of women, from the entertainment industry to mass media to politics, and of course in ordinary workplaces and homes all over the world, it seems to me that this is a good moment for us to pause in a hospital that serves women and was founded by women to honor the reality that the work that we do together really matters. And most importantly, that that work is not done. So what I'd like to talk to you about tonight, and in honor of the 100 women who are working so hard to support our work here at the hospital, is a little bit of a radical analysis, actually, about power, and specifically how we are going to have to shift the balance of power in our healthcare system. Because in order to change our society, we're going to have to change the way that we deliver services to people. And very often, our experiences as women, as citizens, as part of a global community, as patients, as family members, there's a lot of shifting of the balance that needs to take place. So while in some hospitals it might be unusual to hear a doctor stand up and start talking about driving social change, I know that it's not going to surprise any of you because you know this organization. And actually, when it comes to shifting the balance of power, that is a concept that is actually at the heart, in the very DNA of this organization. So to explain what I mean by that, I'd like to begin with a story that I think many of you already know. It's a story that means a tremendous deal to me, which is the story of how Women's College Hospital came to be. In 1865, the vice principal of the Toronto School of Medicine at the University of Toronto, just across the street, flatly denied entry to a young woman named Emily Stowe, who was interested in pursuing a career as a physician. And his exact words to her were, and I quote, "The doors of the university are not open to women, and I trust they never will be." So, at that moment, Emily committed to doing everything in her power to ensure that one day women like me would be able to study and practice medicine in Canada, and that Canadian women would have the option to receive their health care from women physicians if they so chose. And of course, in order to achieve that vision, she had to leave Canada to study medicine. She went to pursue her medical training in the United States. And 2 years later, she returned to Toronto. And despite the fact that she was not eligible to obtain a license to practice medicine in this country, she opened the very first medical practice run by women for women on Richmond Street in downtown Toronto. Now, she probably could have stopped there, right? Because that's a pretty extraordinary accomplishment in and of itself, delivering good care to the women who happened to come through the doors of that practice. But she saw for herself a bigger obligation, a duty to shift the balance of power and to change the structures within the medical profession and across our institutions of higher learning. She knew that we couldn't have a healthy society if we didn't have a just society. So while practicing medicine, she campaigned for the opening of a medical college exclusively for women, a space where women could study medicine for the first time in Canada and where women could receive their care from women doctors. And after years of campaigning and garnering support and raising awareness, Dr. Emily Stowe was granted the right to open Women's Medical College by the City of Toronto in 1883, the very first place in Canada where women could train to be doctors. And the place where you sit tonight is the plant that grew from those roots. So it can be very easy to look back at the challenges that women faced in the past and believe that we've more or less achieved equity today. But the data speak for themselves. At work, in their communities, and importantly, when it comes to health, in all these spheres in our society, sex and gender inequities persist. An organization that was launched to address and challenge those inequities needs to understand how to occupy that space in the modern world and what the 21st century versions are of the issues that Emily Stowe took on with such ferocity in her day. So let's talk about what that looks like. For example, in the world of work. Many of you know that women hold just 34% of management positions in Canada, just 20% of board seats, and that for a host of complex reasons, the income gap persists, with Canadian women earning somewhere between 73 and 87 cents on the dollar that their male counterparts earn. And good luck if you're amongst those that are outside the traditional male-female gender binary. The median income of transgender Ontarians is just $15,000 per year. In my own profession of medicine, women now represent over half of graduates from medical schools. In fact, in some of our Canadian medical schools now, we have 75% women, and they're looking at doing affirmative action to try to make sure that we have enough men entering the profession. And yet, women continue to be underrepresented in high-earning specialties, in the high ranks of academia, and on the boards of our medical associations. So those statistics are not just about dollars and percentages. They are about where the power resides in our communities. And of course, we're seeing an example of those dynamics play out today as we navigate through what feels to me anyway to be an unprecedented focus on the issue of sexual assault in both traditional and social media. Now, not long ago, it was the Jian Ghomeshi scandal, and then it was the spotlight on sexual assault and domestic violence accusation against the NFL players that felt like they were key moments in this conversation, and it really felt as though something was just on the verge of changing. But it turns out, actually, that the conversation was only just beginning. And in the last couple of weeks, as dozens and dozens of women have come forward since the New York Times first published an expose detailing 3 decades worth of accusations against Harvey Weinstein, dominoes are falling in every sector of our economy. So the Me Too movement, I mean, this is the extraordinary thing about social media, right? The Me Too movement in 85 countries, over 4.5 million people engaged in that conversation just in the first 24 hours that it was after it was launched. So people are talking about these issues. People are engaging with these issues. And while much of that conversation has been about sexual and domestic violence, much of it has also been about power and the ways that power dynamics dictate what people feel they're entitled to do, what people feel they can say no to, what people feel they can speak up about. I have to say for myself, when the New York Times reported on the dismissal of Matt Lauer from the Today Show by NBC, I was so struck by the fact that they interviewed all these folks who worked on the Today Show, a show which caters to and relies on an overwhelmingly female audience. And more than half a dozen former staff members told the Times that behind the scenes at the Today Show, jokes about women's appearances were routine, and colleagues had a game that they liked to play, where they would choose which female guests that day or which female staff members they would prefer to marry, have sex with, or kill. And those former employees spoke anonymously to the Times because they feared that their own career prospects in the industry could be harmed if their comments were attributed to them. So that is a statement about power. At the same time, we're seeing men increasingly looking inward and recognizing the sheer reality of women's experiences, that nearly all women have faced sexual harassment or sexual assault at some point in their lives. And that awareness has sparked the hashtag #HowIWillChange, dominated by men committing to addressing their own behaviors and to standing up as voices against sexual violence. The hope is, of course, that we're at the tipping point, right? Of course, we've had that hope before. The tipping point where sexual assault and abuse of power will not be tolerated any longer in our workplaces, in our schools, or in our homes. And we can say, well, it's taken decades to come to this point. The reality is, of course, we don't really know what the point is that we're at. We'll only know, looking back on this moment, whether it was actually a moment that mattered, whether it was actually a moment that led to some kind of a watershed. But a long-term commitment to a vision for gender equity is clearly necessary to truly shift the balance of power, ranging from the right to be free from sexual assault to a shift to larger numbers of women in leadership in every single sector. Now, some of you may be saying, this is all very interesting, but what does it have to do with the work of a hospital? So let's look at how gender and power play out in the world of healthcare. I have to tell you, sex and gender matter in healthcare. They matter a lot. And just as we see income gaps and participation gaps along gender lines in our society, we also face substantial health gaps. Some of those gaps start all the way upstream. Our VP Research, Paula Rochon, who's here tonight, could tell you all about the way health research is conducted and the way it's been conducted in the past in ways that systematically have excluded women. In fact, until the 1990s, women were not included at all in most medical research studies. And even today, many prescription drug therapies and treatment protocols that are commonly used have not been adequately studied in women. When I write a prescription for a woman in my practice, it is very rare that I can be confident that I truly know that this medication has been studied in somebody who looks like her. This discrimination has led to standardized medication doses that are too high for most women, as well as inappropriate treatments for a range of health challenges, with poor health outcomes as a result. Health gaps exist all through healthcare, from the way we manage heart attacks to the way we respond when a woman says she's in pain. Because when a woman says she's in pain, she is less likely to be referred to a pain clinic, but more likely to be referred to a psychologist than her male counterparts. Every year, heart disease kills more women than men, but only 35% of patients in heart disease research studies are women. And once a woman has a heart attack, she's far less likely to be referred for life-saving cardiac rehab than her male equivalent. Women experience depression twice as often as men, yet they're 3 times more likely than men to experience barriers to accessing mental health care services. This is why last year our hospital, along with our foundation, launched a public awareness campaign to engage our community on understanding the concept of the health gap and helping people to understand that we are working to close those health gaps that have a real impact on the lives of women. Of course, raising awareness is very important, but we are going to need to do a lot more than raise awareness if we want to close those gaps. We need to carry out concrete research, education, innovation, and clinical programming that actually respond to the unmet needs of women in our communities. In our early days, that meant pioneering the practice of screening healthy women for early signs of cervical cancer, the invention of the Pap test, or opening the first sexual assault and domestic violence care center in Ontario. There's a long list of historic firsts that emanated out of this hospital because people were paying attention to those gaps. But today, it means something different. It means running the first heart health program in Canada designed exclusively for women. It means running the largest research and clinical program for women's mental health in the nation. It means opening the only hospital-based refugee clinic in the country. It means launching the first trans surgical program in the province of Ontario. And the list of firsts goes on. Each of these examples is meaningful on its own, but it's adding them together that matters. It's understanding how the cumulative effect points back to that equity vision that I spoke about earlier. Now, to be clear, issues of power in healthcare go beyond women and the health gap for women. So if we're really going to strive for a healthcare system that supports equity for everybody, we're going to need to shift the balance of power for everybody. And that means moving from models of healthcare that have traditionally been very provider-centric to models of healthcare that are focused on the patient, or should we call them maybe the person. One of my personal heroes in healthcare, Dr. Don Berwick, who's a pediatrician in the US who founded the Institute for Healthcare Improvement, has done truly inspiring work on shifting the balance of power. In fact, I flagrantly stole the title of my talk from him. He says, and I quote, "If you don't think healthcare is about power, you haven't been paying attention." And he tells this extraordinary hypothetical story. Imagine that I invite you to my house for a dinner party, or to a Pink Cube for a dinner party. And when you arrive at my door, I tell you, this is where you have to sit. I tell you what time you're allowed to eat. I tell you what time you're allowed to pee. I have you undress and put on a gown that bears your backside. I tell you to speak when spoken to. And you're going to say to yourself, this isn't really the kind of dinner party I signed up for. In his words, and I quote, "On the day before I get ill, I am an autonomous, capable citizen. I can fill out my tax returns. I can ply my craft. I can make terrific Italian meatballs. I can binge on 3 episodes of Game of Thrones while answering 50 emails at the same time." And then I show up at healthcare's dinner party, and healthcare strips me. It silences me. It dresses me in a sheet. It takes away my work. It takes away my pleasures, my family. It tells me exactly what to do. Take a breath. Hold your breath. What if, instead, healthcare asked me what I can do and thanked me for doing it? What if, instead, healthcare asked me if I would like to sit or stand, if I would like to speak or remain quiet? What if healthcare asked me for instructions, not doctor's orders, but people's orders? This is the journey our entire healthcare system is on, one that supports people in their own self-care, that determines the goals of treatment by asking the person what her goals are, that encourages people to ask tough questions and arms them with the language they need to ask them. I have to say that that is a hard sell for doctors, clinicians, administrators like me to relinquish our control. But it can be done, and Berwick actually has a whole list that he's published of 8 steps that every hospital can take to begin shifting the balance of power toward the patient. And don't worry, I'm not going to read all 8 to you, because I only really care very much about the very first one. First, he says, you have to want to. It's really hard. It threatens so many assumptions, so many structures, so many vested interests in the status quo, but you have to want to. This is an organization that has always wanted to. That is why I work here. And for many of you, I think it's why you support us. If there is a healthcare organization that understands the underlying structures that lead to inequity, inequality, imbalances in power, and is committed to the challenge of redressing those imbalances, it's Women's College Hospital. So your support is not just support for great research and education and clinical programs, it's support for an organization led by women who are out there fighting for a better world for everyone. Which brings me to the final place where I want to talk about shifting the balance of power this evening, and that's the world of philanthropy. Until recently, men have largely dominated leadership in philanthropy. But over the past 10 years, the increase in the number of women donors in Canada has greatly exceeded that of men donors. Women are now more likely than men to give to charity, and as we work hard as a society to narrow income and health gaps, the impact of women in philanthropy can only grow. This, of course, is an example of a power shift within a power shift, because as one gap closes, which is the disparity in economic power between women and men, so too does another gap close, the potential of women to create waves of change through philanthropic leadership. Now, I recognize that we're in a bit of a bubble here, but Women's College Hospital really is an extraordinary example of women supporting women. Our women patients, who do represent 75% of the people we see here for their care, inspire us with their resilience, their courage, and their determination. But this hospital has always been about more than the patients. Over 70% of our leadership team are women. Women dominate both the hospital and the foundation boards. And we have a strong history of women supporting this hospital as volunteers, as longtime monthly donors, as million-dollar donors to this incredible 100 Women community. And so, as Mary said earlier, our foundation is unapologetically striving to be the charity of choice for advancing health for women. And we are unapologetic about women taking the lead, whether in our day-to-day work or through major events like this one or like Women for Women's, because the more we push this position, the more normalized it will become, and the more the balance of power will begin to shift. So what's the takeaway from all this? Shifts in social structures, including the structures of the healthcare system, have never been easy to bring about, and they're not going to get any easier. Whether we're breaking the silence of decades around sexual assault, demanding that our drugs and treatments be safe for women, or taking our rightful place in the world of philanthropy, creating change is hard. It requires the kind of commitment that Emily Stowe showed, the commitment to roll up our sleeves and do the work for each individual patient who comes through the door, together with the unapologetic drive to change the rules and the structures to make a system that's inclusive of everyone. And of course, Emily Stowe didn't do it alone, nor will we be able to. We need our community, including the men in our community, to work together with us to achieve the bold vision we've set for ourselves, and that includes all of you. We are very grateful for your leadership and for your partnership on this journey. Thank you for investing in this work and for the vision we share together to create a healthier, stronger Canada for all. Thank you.
I'm curious to know about women in philanthropy. In particular, as more women have assets to give. It does not necessarily follow that they will give to women's things.
I think that's true, and
how do you deal with that?
I think that's true, and I think well, I mean, perhaps it's a question better directed to our foundation because I'm not a professional fundraiser. You know, I don't think that every woman is going to give to, you know, so-called women's causes, nor should we. I mean, women have diverse interests, just everybody has diverse interests. But I do think there is a place, and I'm interested in understanding from all of you whether you think this is a message that will carry in that universe of women who have the money to give to a cause like ours, because I do think that there is an important place to be unapologetic about it, and to say this is something that we will ask men and women to support this hospital, but we will specifically ask women to support this hospital because we think that's important. But I mean, there are people here who know more about fundraising than I do.
But I do disagree with your premise that, you know, we should support everything. I'm not opposed to supporting everything, whether it's orchestras or whatever it is. But if I sit next to Paula Rochon and she gives me a 10-minute blab on why the medical profession will not do sex-segregated data, why women's health is not managed, then don't tell me you're going to give to the TSO without insisting half the orchestra players are female. So wherever you go, it's not good enough to say otherwise.
I'm with you.
All right.
I wouldn't want to be against you also. No, I'm with you. I mean, I think that we have to, we are trying to build something here that matters, and it's not a trivial exercise. And I didn't even get into in the talk, you know, that the universe of women within women as a group who are marginalized and vulnerable. I didn't even talk about Indigenous women or refugee women or women with addictions or any of those subgroups of women who, you know, are facing a much more steep uphill climb than everybody else. So there's no end to that work. You know, the question that that I am sometimes asked is, you know, well, are you about women or are you about innovation? Like as though you can't talk and chew gum at the same time, you know, as though we don't know how to multitask. And I think, you know, the answer is, of course, we're about both. But I think also specifically when we talk about the health system solutions work, about the research work, the education work of the organization, helping people to understand that when you fix a process for women, you fix it for everyone, and that when you address inequities and gaps in the system, you close them for everyone, but that we are not going to apologize for starting from the assumption that the gaps for women need to be closed. I think that's a powerful message, and so I don't see the innovation work and the Roots as a women's organization as being in tension with each other. I think that they are one and the same. Yes, Colleen.
So I think one of the other things that Women's has been able to do is do research against things that are women's-based health issues, right? So if you think about the work that we've done around BRAC and how that work would never have come to the front, and it's allowed thousands of women to be diagnosed early and have a pathway that is a healthy pathway. Like, I don't have any issue with investing in women's health care because it's good for a larger group. Like I find it odd to think that someone would think that that was a bad thing. Like I would not invest in technology that would help my business, right? It seems very odd that anyone would have the kind of view that you have. The other thing is that I was a scuba diver my entire life, and I jumped in the water off, you know, Navy SEALs dive tables. They weren't my dive tables, but I still got in the water all the time. We need healthcare research that is customized to our bodies and our features that are very different than men's features. We don't have the same body mass. We don't absorb drugs the same way, and I don't really know why I have to justify that to anybody. Like, I just think it's healthy to have that done because the other is already done. So, yeah, tell them to get stuffed. It's a new rhetorical.
That's a good one. Yes.
What was the number 2 thing on the list of things you needed to do to help?
Oh, you're testing me. I have to pull up the whole list. One of the big premises of what he says that I've had, he's a big humanist, Don Berwick, and a brilliant writer. If you ever want a good cry, you should Google the convocation speech he gave at the Harvard Medical School called To Isaiah, which I read every once in a while just to remind me about why I'm in this line of work. He talks about this notion of accepting the gifts that patients bring, which is about organizing your entire the pathways in your organization around trying to ascertain what is it that the patients are bringing to the table that can be used for their own care. So he's got these unbelievable examples, for example, of these folks who are self-dialyzing, doing self-dialysis in an ambulatory hospital in Sweden. Where basically one day one of the patients who was coming in for the 5,000th time said, "Would you just show me how to work the machine?" And the next thing you know, it's peers training peers, and the unit is open 24/7, and people can come when it works for their lives, and they hook themselves up, and they know how to, get into the catheter themselves, and they just dialyze themselves. Or this little boy who has a genetic condition that requires him basically to be fed via a nasogastric tube. So somebody has to put a tube in through this kid's nose and into his stomach 3 times a day. He does it himself. There's these things on YouTube of him teaching other kids how to put in the NG tube themselves. It's not about downloading work onto people. It's about saying, what have you got to bring to this endeavor? Let's do this together. What role do you want to play? And that's what he calls it, accepting the gifts that patients bring, but it's actually quite concrete. Like, this is what's going to need to happen. Which part is going to be your job and which part is going to be my job, and we might switch it up next week depending on what you're in the mood for. But we don't assume that you're just lying in captivity on a bed waiting for others to do things to you. You are a participant in that process. So it's it's a radical redesign of the way that we think about healthcare. But that's another one of my favorite ones, is accepting the gifts. Yeah.
Has this model been done anywhere? Like, has it been?
So he uses examples. This. Shifting the balance of power in this talk and the stuff that he's written, Don Berwick, he uses these examples of what I would call leading practices. So the self-dialysis unit is one example. He's got, there are dozens and dozens of such examples, and including, in Canada, it's not like we don't have innovative models of care delivery. But of course, the problem is that if you want self-dialysis, you have to live in that region of Sweden because nobody else is doing it, right? And so it's this, I talk about this in my book actually, the problem of spread and scale in healthcare, that we don't seem to be able to take those successful models that have been shown to work in one place and scale them up across our healthcare systems. And so you end up with these islands of excellence in a sea of mediocrity, and that needs to be, that's one of the big system challenges that we grapple with. So, but yeah, he's got lots of examples. I don't think that there is any example of a single organization that is doing it top to bottom, including here. We have lots to learn about how to do this well. I just think we have the right ingredients for it. So, yes.
What will be the function of artificial intelligence in patient care?
So there is a short and a long answer. The short answer is very, very soon there will be tasks that are currently done by people in healthcare that will be done through machine learning, just as in every other sector of society. The classic example that gets used all the time is radiology. So in the artificial intelligence world now, I am told, and this is not my area of expertise, that there are algorithms that allow a machine to do as well or better than a trained radiologist, certainly in separating out all of the normal from the abnormal, X-ray, CT scans, MRI, whatever it is. So one imagines then that it won't be that long before the machines can also learn to differentiate which particular kind of abnormal you're dealing with. But even if the machines just weed out the normals, I mean, that's 95% probably of many of the kinds of scans that we do. So there are specific tasks. Much of medicine is pattern recognition, and certainly in the in the area of radiology is a classic example where pattern recognition, anything that is about pattern recognition, a machine can be taught to do, and that's what AI is all about. What will be the kind of end state of all of that, when we live in a world with self-driving cars and we don't ever interact with a human in a bank or a grocery store anymore, and things kind of like drop through some chute in your ceiling or whatever. I don't know. I actually don't. I don't think anyone has really. I'm sure somebody has imagined out that end state, but in the very, very short term, there are applications of AI that are coming in healthcare and medicine. The thing about it, of course, will be that in the early stages, it will be very expensive. Very expensive. And so until the technology goes through its normal course of things where it starts out expensive and then gets less and less so over time, are we going to be prepared to invest, and what's the opportunity cost of those investments? Like if we could immunize the nation against measles or have one Watson that read all the x-rays, how do you make those? Those are social decisions, those are choices. There's nowhere where the resources are unlimited. And so that's going to be a really interesting conversation. Well, thank you for being my test audience for this talk. If people have feedback on it, I'm very interested in hearing it, and I really appreciate the opportunity. Thank you.
Thank you very much, Danielle. And I know we told you where to sit today. Hopefully, beyond that, you felt that you've been able to engage in free conversation. And our intent really is that the conversations that we've started today will continue with your friends, with your colleagues, with your family, and spark discussion and debate about some of the ideas, because we really are looking for equitable access to health care for all. So thank you again for your support. Thank you for being here this evening.